morning or good afternoon or good evening, wherever you are. My name is Dr. Jacqueline Ong. I am a staff physician at the Pediatric Critical Intensive Care Unit at the National University Hospital in Singapore. And I have been very kindly invited by the organizers of the International Fluid Academy to give this short talk on the fluid management in the pediatric population. I'd like to thank the organizers for this kind invite. It was really through the power of Twitter and social media, and I'll come back to that at the end. But yes, I'd like to thank the organizers for this very kind invitation. So today we have just a short period of time to talk a little bit about how we manage fluids in children. And we'll keep it fairly straightforward in terms of management. You realize that there are not that many differences per se between adults and kids, at least in this respect. I have no financial disclosures. So the overview for this session is really in four areas. One would be how we calculate fluids for children, the type of fluid that we give, how we manage fluid in critically ill children and in septic shock, in the area that's close to my heart. And then, of course, the ongoing work that is being done in terms of the use of balanced solutions in children. Now, how much fluid do kids really need? What you're seeing here is a table which really has shaped really how we give fluids in kids, and it's pretty universally used in many centers around the world. This was really formulated by a landmark paper by Holliday and Sagar in the 1950s. It was published in Pediatrics. It's really derived from estimated water requirements from healthy, active children. And you will see that you can either use a 4-2-1 rule, which is on the right-hand side for the hourly fluid requirement, or a daily fluid requirement based on the weight of the child. So based on this formula, a child who is 20 kilos would get 1,500 ml of fluid. I'm going to say that it's likely an overestimate of requirements for maintenance fluid in non-dehydrated children. The fluid requirements are from children who are active and healthy and really not the same as children who are sick and hospitalized, and in children who actually are not dehydrated in the first place. So I think there's generally a sense that the Holliday-Sagar can be an overestimate, and in many centers, and particularly intensive care units, there's a move to really restrict fluid to about 80 or 90% of the volume that's calculated from the Holliday-Sagar formula. Now, what kind of fluids can we use in children? Again, this is taken from a really nice review by Sarah McNabb just 4 years ago. You will see that, at least from the original Holliday-Sagar paper, they estimated that the electrolyte requirements for a child for sodium will be 2 to 4 millimoles per kilo per day, and potassium 1 to 2 millimoles per kilo per day. Because of these sodium requirements, that the children generally needed about 2 to 4. That was with the formulation, as you can see with my pointer, that's resulted in this hypotonic fluid calculation, solution composition of what sometimes we call quarter normal saline, or 0.18% sodium chloride with 4% glucose. The next formulation that's usually available in many places is half normal saline, or 0.45% sodium chloride with 5% glucose, both of which unfortunately are hypotonic solutions. And this was really derived because in general, a child who's maybe about 10 kilos will maybe need 3 millimoles of sodium in a day. And that's really where it came from. And this really shaped our fluid calculation for children for the subsequent 50 years. And as you can see, we use this all the time. You will note that on this table also there's isotonic fluid, like normal 0.9% sodium chloride with 5% glucose, which we often give for children, Plasmalite, and then another balanced solution with Hartmann. So this is a comparator table in terms of what is available. However, I think in the last 10 or 20 years, there's really been a move away from hypotonic solution. We really use it at our own risk, in part because of the recognition that severe hyponatremia was occurring in hospitalized children around, especially in the end of the last century, 80s and 90s, in association with hypotonic fluids. And these kids, unfortunately, were having severe neurological morbidity and death due to cerebral edema. And this was thought to be in association with the administration of very hypotonic fluid, in particular the quarter normal saline of 0.18%. And we recognize still that hyponatremia remains the most common electrolyte abnormality, affecting about up to a third of hospitalized children. Now, why might this be the case? Well, in part, in many ways, it is due to this. So this slide demonstrates the secretion of antidiuretic hormone from the posterior pituitary. The secretion of ADH results in free water retention, leading to hyponatremia. This response in children sometimes can be quite excessive or relating to a syndrome of inappropriate ADH. It can occur in most of the reasons why a child may be admitted to the hospital. So pneumonia, asthma for respiratory conditions. If you have head trauma, meningitis, again, that can trigger excess ADH secretion, malignancy, and even nausea and pain as a stressor can result in excess ADH secretion. So you have the combination, obviously, of having a child on hypotonic fluid, which has an excess of free water, in conjunction with the secretion of antidiuretic hormone, and then subsequently combined by an overestimate in fluid requirements, really will create, as you can imagine, a perfect storm for hyponatremia, resulting in unfortunately, a catastrophic consequence. Now, by and large, normal children with normal renal function will clear the free water without any issues, which is why even in the 50 years, the case reports were isolated. Nevertheless, I think the risk associated with hypotonic fluid is significant. It is iatrogenic, and if it can be avoided, we should, because children who receive isotonic fluid can also clear, with normal function, can also clear the sodium. The caveat is, of course, that if the fluid that you're using, whether or not it is isotonic, there are some concerns among, especially some centers, that giving isotonic fluid in the form of normal saline, we'll come back to this, but normal saline is not without its own risks, as we'll come back to. And also there are concerns from renal physicians that sometimes the administration of such high amounts of sodium chloride may exacerbate hypertension in their end-stage renal failure patients. So I think the caveat is, I think the quarter normal saline, the 0.18% saline should be definitely removed. Any other use of other saline the children should be monitored for features of hyponatremia, fluid overload, and that may involve electrolyte monitoring as well. So the first take-home message really is that using the Holiday Sagar fluid calculation for children in the hospital is likely to overestimate the requirements, and we need to tailor that appropriately. There is a risk of hyponatremia, and that can be significant. And excessive ADH secretion is not uncommon in sick children. And we should really administer isotonic fluids for hospitalized children if IV fluids are required at all. And I think there's also some pragmatism to that, in that not all hospitalized children really require routine IV fluids if they can take orally. And the only limited circumstances where they really, such as in actively dehydrated patients, where they may need intravenous fluid. So I think being pragmatic about this is also important. Now, moving along to the fluid management in specific populations, I work in a pediatric intensive care unit, and obviously managing fluids on a daily basis is part and parcel of what I do. Now, I just like to draw your attention to this paper that was published a little while ago, a couple of years ago, which was a really excellent, I think in my mind, a landmark paper in terms of looking at the association of fluid balance and outcomes in children who are in the pediatric intensive care unit. This systematic review and meta-analysis looked at 44 studies from a range of populations in the PICU and included over 7,000 children. For pediatric papers, that's a lot. Our papers are usually small in terms of looking for effect, but 7,000 children is a lot. They most commonly defined percentage fluid overload using this formula, which is proposed by Stuart Goldstein and certainly is recognized widely in terms of what is commonly used. And they found that in these 44 studies, there was a wide variation in the extent of fluid overload, with some paper actually quoting up to 83% fluid overload, a fluid overloaded child by 83%, which is a lot. The median was somewhere around 30%, which is 30% above the weight or percentage fluid overload is significant. But to however much the degree of their fluid overload, whether it be low or high, across all groups, this was associated with increased mortality of more than 4 times odds ratio of mortality. And this is enormous in pediatrics. I think in the way that intensive care has advanced, children, the mortality in the peds ICU across the board in many centers around the world is less than 5%. And so therefore, I think the concern that nowadays, I think in pediatric intensive care, what we're looking often is morbidity and what happens to survivors or peds intensive care, but mortality is rare. So the fact that this, what seems quite simple in terms of managing fluids, could have such a significant effect is important to look at. But the odds ratio of 4 is incredibly high. It's associated with worse respiratory outcomes, acute kidney injury, and increased length of stay in the PICU. And this is also reiterated for adults. It is not kids alone. And I think what is something that was pointed out by Sarah McNabb's review, or which I mentioned earlier, was that what we also need to do in the PICU is also be quite careful in terms of the amount of infusions that we run for children. All the what we think are small continuous infusions all add up, especially if the body weight of the child is only 4 or 5 kilos. Then every drop that we give may have some significance in dealing with the percentage fluid load for the child. So I think this quite clearly showed, as a summary of the available data, was very nice in terms of showing why we should try and avoid fluid overload in children in the ICU. So with that, I think it's a quite obvious take-home message that it has adverse outcomes, and then we need to restrict our fluid intake in the pediatric. And as mentioned previously, a lot of the times, many intensive care units will choose to cut back their maintenance fluids for children who are nil by mouth to 80%, and even less if they're mechanically ventilated, as the amount of insensible loss from these children is much less, as they're exhaled into a closed circuit. Now, moving into fluid management for pediatric septic shock. Again, this is an area that has generated a lot of discussion in the last 10 years, really because of this paper. You can't really give a talk on fluid management in children without actually name checking this landmark paper by Catherine Maitland, the Feast trial, that it's actually almost coming up to 10 years now. In this paper, they looked at what was happening to African children with an acute febrile illness with impaired perfusion. This was done in a resource-limited setting. Dr. Maitland did an incredible job, and her team did an incredible job in terms of trying to conduct this randomized control trial across many centers in settings where setting up a trial is not straightforward. Of course, why this generated so much controversy was, of course, it's encompassed in these two Kaplan-Meier in these two graphs. Essentially, is to look. It showed that both at 48 hours and a persistent effect at 4 weeks, that children who were receiving bolus therapy in the form of either saline or albumin had a worsening outcome, that the mortality was increased, and this effect persisted at 4 weeks. This either saline or albumin, actually, there was an increase of 3% in mortality. And because of this effect, this trial was actually stopped early. And this caused reverberations around the world, really, because up to that point, and still is, standard fluid resuscitation for septic shock requires bolus therapy in the form of saline, or either crystalloid or colloid. And even Dr. Maitland, on explaining this trial, which she did for many years and continues to do so, at the beginning, they were not expecting this result, because up to that point, conventional wisdom had said that giving fluids was the right thing to do. Although it was possible to carry out this trial in Africa because there was equipoise in terms of whether or not this was likely to be helpful. And really, it's because of, the questions really that generated from it was this generalizable? These were kids with a high proportion of malaria and anemia. It was a resource-limited setting. They had very limited access to intensive care support, limited monitoring. Was this why the children were actually becoming incredibly sick, because there was limited support? Maybe the concerns about fluid overload was also exacerbated here. To be fair, despite on many reanalyses of the data by Dr. Maitland, her group, and then repeating studies in other places with a similar background, I think that to date, there's really no clear explanations to why this has happened in this group. Of course, it's a unique cohort. It may not be generalizable to children who do have access to monitoring and to intensive care. And also the spectrum of disease with a high proportion of malaria and anemia is unusual in resource-rich settings. But this has obviously shaped through kind of a bombshell into how we routinely resuscitate kids with fluids, and perhaps that not all of it is benign. Which brings us to actually this really interesting paper that was done by Michael Levine and his team. It's a combination of a group from London as well as from South Africa, which re-looked at the FEAST trial data. And they they wanted to know really what was it? Is it possible to derive what exactly went wrong for these children? And they formulated novel composite scores from the FEAST trial to compare changes in respiratory, cardiovascular, and neurological function. And they compared to other cohorts, one cohort in Malawi with malaria, as well as another cohort in London to ensure the validity of these scores. And they found that in the FEAST cohort, that the volume expansion actually appeared to worsen the respiratory and neurological scores, but did improve cardiovascular function. And this group actually proposed an interesting theory that you have these children who are already anemic. They subsequently receive an albumin or saline bolus. This results in hypoxia and reduced oxygen delivery, which generates a metabolic acid. That, combined with the hyperchloremia from normal saline, results in more acidosis. They become fluid overloaded, and they may have increased cerebral edema, which is worsened by the fluid as well as the impaired oxygenation, all of which then combine, unfortunately, to result in death. because it was not immediately clear why these children had increased mortality at 48 hours, and that persisted. So that was very interesting in terms of their postulation that this is the reason why these kids were doing more poorly. This has really shaped the changing surviving sepsis guidelines. And this was really on this publication, the newest iteration of the surviving sepsis guidelines from the Society of Critical Care Medicine in the US. This came out in February this year. It's a large group that have come together to discuss what are the international guidelines. And you will see that their algorithm for managing children with septic shock is actually divided into whether children are in intensive care or in healthcare systems without intensive care. And this is a great change from what previously was suggested. So you will see that if you do have healthcare systems with intensive care and their features of abnormal perfusion, with or without hypotension, they have changed, and previously they would not have thought 10 or 20 mils per kilo was a problem. Now they're being more careful. They would give 10 to 20 mils per kilo, and they would continually reassess the child until either shock resolves or fluid overload develops, and also to commence early inotropic support if necessary. If you are in a healthcare system without intensive care, based on the evidence that was provided with the FEAST trial, it says that do not give fluid boluses unless there are active signs of dehydration, such as diarrhea. And it was important to note that in the FEAST trial, if a child came in with an active inotropic support, then came in with an active diagnosis of gastroenteritis, that they would actually they were not actually included in the trial because the child had active losses and they received standard fluid therapy. If there are features of abnormal perfusion with hypotension, they said cautiously give fluid and not more than 40 mils per kilo. So I think that this recent iteration of the surviving sepsis guidelines is really shaped by what FEAST has shown and the concerns about fluid overload over time in resource-limited settings. Now, take-home message number 3 then is, of course, fluid bolus therapy in children with pediatric septic shock should be performed with some caution, particularly if you're in a resource-limited setting. You can start a bolus, obviously in healthcare systems with intensive care, 10 to 20 mils per kilo is reasonable, but it is really important to frequently reassess for reversal of shock and fluid overload. Okay, so to round off then, therefore, what about balanced solutions then? So I said I would return to this, and really in the original table that I showed, there were 2 balanced solutions available, Plasmalite 148 with glucose, as well as Hartmann's solution. And those are certainly available for the use in children. And why it has gained great traction in the last little while is really because the presence, as already seen by Dr. Levine's paper, is that hypochloremic metabolic acidosis is a problem in children as well as in adults. Right now, we are still pending prospective studies in terms of the use of balanced solutions in children, but I think that's certainly well described on this platform with the International Fluid Academy, as well as in papers that presented that hypochloremic metabolic acidosis is an issue in both children, in adults with worse outcomes. Now, Plasmalite is probably the one that has gained the most attention in the last little while. The recent work has shown a few aspects that there are lower increases in chloride in certain settings. It's perhaps better than normal saline or 0.9% saline children with acute gastroenteritis. In the cohort for abdominal surgery, it seemed to be better and better acid-base balance. And certainly there's some evidence that there's a better outcome with use of balanced fluids in pediatric septic shock. And certainly currently the most recent iteration that it was actually recommended for use in ped septic shock, although this was, the evidence was still considered to be weak, but certainly has emerged in present day guidelines. So take home message number 4 is that it is safe for use. We have used it in a wide variety of settings. It seems to be safe for children, and it reduces the incidence perhaps of the hyperchloremic acidosis, particularly in settings such as diabetic ketoacidosis, where traditionally children have been getting large amounts of isotonic solution in the form of normal saline. Maybe there's better outcomes in a wide variety of settings, and it's important in kids too to avoid hyperchloremic metabolic acidosis. So with that, that's the end of my brief talk. I hope that it's been useful for those who have been listening. I'd like to thank you from Singapore. This is where we are. And as I said at the beginning, this talk was only possible from Twitter. My Twitter handles are there. It's my personal